very much. Thank you very much for joining. Arshad साहब भी हैं, Dr. Alia हैं, हाँ जी, and Dr. Shahzad. Okay, I think we can start, and our colleagues, Parliamentary Secretary and Ma'am Rubina Khurshid will join later. So, as on behalf of SDPI, I welcome all worthy panelists and my all participants to join this webinar, very important webinar. The purpose of webinar is to know more about the program, which is taking care of the health of the people of Pakistan, and which is very important. Health is, as we all know, that important determinant of economic growth. This program in Pakistan was launched in is in 8th year and started in 2015 on the basis of Wasila Sehat program, piloted in 2012. This social health insurance program is unique in Pakistan as it is universal in 2 provinces of Pakistan, and 100% of the premium is paid by the government. And so this topic is to know more about today's what is happening today in this program, as the CEO of Sehat Sahulat program has joined us. And we will ask him about this thing. And we see it is what is the future of this program, as the policy makers, like the political representatives, will be joining us soon. So we want to know that as this is the election year, so what is happening in their manifestos. So that will be great if we can get some insight on that. So I just want to give an overview of the social health initiatives in the region. So in the region, or the best practices in the world which can be replicated in the Pakistan, like for example in Taiwan's national health insurance, and Chile's national health insurance program was, I could find it many similarities or many good practices which can be adopted in Pakistan, and which can bring us good outcomes. So I will just present an overview of the program. Taiwan's national health insurance is more than 20 years old, and this was reforms were made in 1995 when they combined all the individual health insurance programs together. So as it socio-demographically, Taiwan is about 23 million people living in Taiwan according to the 2022 calculations, and 16% of the population is more than 65 years. And the GDP is, though it's very high from Pakistan, 28,000 USDs, and total health expenditure is 6.54% of the GDP, which is, as in Pakistan, it is 3.5%. So the labor insurance, this 3 programs like labor insurance, government employees health insurance, and the farmers insurance, they were combined together in 1995 and under the National Health Insurance Program. And this was running very smoothly, and before that, the 59% of the population was utilizing this program, but these programs were benefited. But after that, about 90% of the people are being benefited from this program. And in 2023, to address the shortcomings of the National Health Insurance Program, they launched the 2nd generation, which was with innovation and the technology advancements, which gave them the better idea. So this was to improve the 2nd generation program had the improved quality of healthcare. It ensured the soundness of the finance and encouraged the public participation. So it was, although it is voluntary for healthcare, one of the important points for this program was that although it is voluntary for the healthcare providers to join this program, but it is such a nice program that the 93% of the providers nationwide have joined the NHI. So these providers are being supported by the reimbursements and by the co-payments. And the premium subsidies are co-payments or waivers have been granted to the disadvantaged through the, so this program also take care of the vulnerable population or disadvantaged. So if we look at the healthcare system of the Taiwan, so 83% of this, the healthcare is outpatient care is provided by the private sector and 17% by the public sector. And if we look at the last one is 74% is inpatient care is provided by the private sector and 26% by the public sector. And this is our program is concerned only about the Sehat Sahulat program is concerned only about the inpatient care. So this is and there are different models of the payments. Like for example, the insured person is about for the outdoor care, they do the co-payments according to their like the population or the they are whole population is divided into 6 categories according to their income and the ability to pay to do the payments or the co-payments for the to make it smooth. And each person remits the general premium according to their fixed figures or according to their level of according to their category. And 30% of the for the salaried employees, they have to pay 30% of the premium with their employees paying 60% and the government supports 10% of that. But the vulnerable populations, like for example the low income households and military, they are being 100% is paid by the government. And then ensured there is a mechanism of actually the healthcare is not denied to anyone. So there is a mechanism of the cost sharing mechanism where the different categories they combine, and then the healthcare is not denied to the lower income or in the catastrophic health diseases or in the other in the remote areas where the insufficient facilities are available. So, but this is the benefit of the co-payments. They could see that as an outpatient care, the unnecessary utilization is being controlled. So that's why we can compare it with our system in employee social security institution, which is 100% free, and this is there is no co-payment for this, which results in the overutilization or the unnecessary utilization, you can say. The average utilization rate of the healthcare system is outpatient services in 2020 was 14.2 visits per person in 2020. And for the indoor cover, there was 14.12 admissions per 100% in 2020. And the number of outpatient visits is substantially higher than that of many organizations for OECD countries. So that is the shortcoming of this program, the overutilization. But there is, as I mentioned earlier, that the people who need care, they can, like for example, the hemophilia patients is also treated under this program, and their cost of is 97 times more as much as the average patient. So that they are also being treated. The information system of the National Health Insurance is very, next slide please. It's a key strength of this program, because this program controls all the pilferages or all the frauds or any overutilization or underutilization of the services, or because with this health system, with this health information system, all the data is with the care providers. And they can see, and recently in 2004, they introduced a smart card, which has the last 6 months data of that patient, so that they can be tracked. Like for example, they utilize this card for tracking of the contacts during COVID-19, and they could see that this next slide please. and they could track the patients which were traveling or which were having contact with the ANBO. This card is very effective to understand what this patient needs and what is the overutilization. So that is also important innovation for this health system. And if you talk about the patient satisfaction, about 90.2% of the patients or the utilizers are very much satisfied with this program. And but this system also has challenges which are which needs technological advancements and innovative approaches to deal with. For example, there is life expectancy is increased, and so they need some innovation how to deal with these, because they include the home care also. So these are the and that second is that the biggest beneficiary of the national payments are the hospital operators. So the how to control or regulate those hospital operators to not to earn too much profit and to deal but healthcare providers are sometimes being neglected or being misused by these hospital operators. So these are the challenges which are if we compare with the Pakistan, so the Pakistan's health budget is only 3.5% of the GDP. And we have huge population around, I think, 340 million population with this, 240 million with this census. And there is a double dipping of the facilities, and there is continuation of the strategic actions are also. So there are different programs in Pakistan working in Pakistan, like employee social security institution, corporations, philanthropy, army, public health system, private sector, and there are a system of reimbursements also. So I think if we look at Taiwan system, or it's just an example, like if we pool all these systems together so that we can have a better sustainable universal health insurance. So I think this is the main thing to talk for this today's webinar. So now I think this was an overview. So now I would invite Mr. Mohammad Shahzad, Dr. Shahzad Ali Khan, who is the VC HEC and VC Health Services Academy, and a very renowned public health expert, to talk about this for the continuity of this health program, and what is the effect of this health social health insurance on the out-of-pocket spending of, which is still 52% in Pakistan according to the national health accounts in latest national health accounts. So that is for the and how we can go about the sustainability of universal health insurance, and what is the role of the gender sensitive policies in this program. Over to Dr. Shahzad Ali Khan. Dr. Shahzad Khan. Dr. Shahzad, are you there?
Hello.
Yes, Dr. Shahzad, we can hear you, please.
जी आपको आवाज आ रही है अब?
जी आ रही है आवाज.
अच्छा चलें. Thank you very much. I think it's a very right time to discuss these issues of social health protection, and specifically these out-of-pocket expenditures and the way Sehat Sahulat program and social health protection has been working. आपने जो the slides you showed, there is enough evidence. There is enough evidence and a very high number of sample and a very big population which was covered through this program. Most of the indicators have shown a huge improvement, which means that there are so many benefits, even in the, I will call it, infancy of the program. Dr. Arshad will tell you, and he has a lot of knowledge about global experiences, how these programs evolved. Most of the programs, they took at least 100 years. So the oldest program of social health protection, it took 150 years, 1840, social security system, a Bismarckian model, we call it, Otto von Bismarck in Germany for workers. It took around 150 years to get 80% or maybe 90% coverage in Germany. Similarly, in many other countries, no country has done such a huge health intervention in few years, like 3 years, 4 years, or 5 years. It needs at least 3-4 decades to reach to some level. So this is something which Pakistan did quite greatly. Issues will always be the same which the other countries have borne, like sustainability of the government financing in this financial and economic crunch. The way the government is sort of thinking of taking more loan and taking some softer loans and better interest rates, and the pressure of the international financial institutions on the government to reduce the fiscal deficit, to reduce the government expenditure. So these are the things which are challenges for the program. So I will hope that, and you know, it's the history of even thinking on social health protection or health insurance or similar programs is not more than 20 years. So in 2002 to 2006, there was a poverty reduction and income distribution, CPRID, in the Ministry of Finance. It was supported by UNDP. So they did, so it's 20 years ago, they did some surveys, some assessments, evaluations 20 years ago, that what is the basic reason and what is the most important reason for poverty in country, in Pakistan. So they were estimating the incidence of poverty in Pakistan. And no one expected that the result will show that the healthcare cost, which you labeled in the title of my talk as catastrophic expenditure or out-of-pocket spending, no one in finance ministry, planning ministry was expecting that in Pakistan, the highest number of poverty incidence is because of catastrophic expenditure of the out-of-pocket spending. So in 2006 and 7, the Planning Commission and other planning bodies and finance, they started talking about out-of-pocket expenditure. The World Bank and other organizations, they also started talking about out-of-pocket expenditure and catastrophic expenditure. And then all of us, we actually got hold of something which we call it as social health protection, and then targeting programs, and then social health insurance. So this is the evidence-based thing. There is evidence in Pakistan that the highest incidence of poverty is because of this healthcare cost, out-of-pocket expenditure, and there is something which can be managed by targeting those households who cannot bear this cost, and definitely taking some premium or some allocations on a monthly or yearly basis from those who can afford. So I think we can hear from Dr. Arshad and other colleagues, Dr. Alia, what is the economics and what is the sustainability portfolio of that. There is evidence that catastrophic expenditure are dangerous. There is evidence that out-of-pocket spending is quite common. So we must continue with similar schemes. And you can change a little bit of design. You can change the eligibility criteria. You can add some of the premium from pooling and other premium options for the middle and upper middle income and the rich class. But there has to be some systematic manner in which this program should be strengthened. Over to you, Razia.
Khan, for your worthy contribution. And now I would request Mr. Mohammad Arshad Sahab, the CEO of Social Sehat Sahulat program, to my question to you is like we are just in the second year of universal health insurance in Punjab. and it is in ICT also. And what is the future of this social help as a universal health insurance program? Though it is not including the outpatient department, but what is the nexus between the universal health coverage and universal health insurance programs, and how can we adopt the different examples in the region or the best practices? Over to you, Dr. Mr. Mohammad Arshad Saab.
Assalamu alaikum ji. I hope I'm audible.
Yes, loud and clear.
Thank you, ji. Thank you, Dr. Razia, for inviting me, and I will continue what Dr. Shehzad has mentioned in his talk. That हमारे जैसे मुल्कों में या जो और अदर डेवलपिंग नेशंस हैं वहाँ पे यूनिवर्सल हेल्थ इंश्योरेंस रिलेटिवली एक नया फिनोमिना है, और जैसा कि अब एविडेंस और एम्पिरिकल एविडेंस ये बता रहा है कि जी 56% ये से कुछ ज़्यादा लोग गुर्बत का शिकार इसलिए होते हैं कि कैटास्ट्रॉफिक हेल्थ केयर एक्सपेंडिचर से उनका वास्ता पड़ता है। यही बैकग्राउंड था जिसमें बहुत छोटे से साइज से इस प्रोग्राम का आगाज किया गया था। We used the BISP data and we were evolved in a very fast way, fastest in the health insurance history, जितनी human history है। और हम उस 3-3.5 लाख लोगों से लेके आज हम जो है कोई 185 मिलियन पाकिस्तानियों को, एक ये बड़ा मसला है कि लोग कहते हैं कि अच्छा ये पंजाब की हेल्थ इंश्योरेंस है। नो, इट्स कवरिंग ऑल पाकिस्तान एक्सेप्ट सिंध एंड बलोचिस्तान, which is 80% of Pakistan's population. This is why this is world's biggest national health insurance program, fully state funded, for covering for the inpatient coverage. And the good news is next month Balochistan is also joining, so that there will be only Sindh will be remaining. Otherwise almost तकरीबन 26-27 करोड़ का नया नंबर आ रहा है हमारे पास पॉपुलेशन का, उसमें से तकरीबन कोई 20 करोड़ पाकिस्तानी जो होंगे वो they will be benefiting in the UHI. Or in Sindh, we have already covered Tharparkar, and now the federal government is considering another 5 districts to be covered under the backward district areas coverage program for the UHI. So remaining Sindh पे हमारी discussion चल रही है. Hopefully they will join soon on the current year or next. ये तो थोड़ा सा जर्नी था, जैसा कि आपने बड़ी अच्छी बात की डॉक्टर रजिया के it's a big milestone forward towards achieving the UHC. Universal health coverage is a more an ideal direction or ideal destination for every nation. कोई दुनिया में 100% भी नहीं है in any part of the world, लेकिन ये कि we are finally getting in the direction जहाँ जो catastrophic healthcare expenditure है, which is mainly caused by the inpatient or sometimes in the chronic medication for the outpatient coverage, जो कि आदमी को खानदान को कहीं का नहीं छोड़ता in terms of financial destruction, and उससे गुर्बत के जो शरह है उसमें इजाफा हो जाता है। तो we are moving in the right direction. We are already conducting couple of primary health care projects, pilot projects in Islamabad, Muzaffarabad, and Faisalabad now, just to integrate the health coverage for the inpatient and outpatient together, and also coming up with another prevention project, pilot project, with the help of the HSA and WHO very soon. So we strongly believe that this prevention and PHC is equally important for integration of the healthcare system in Pakistan, not only to save the money at the secondary care and tertiary care level, but also to save lives right in the beginning of the patient journey. Third thing is, एक जो बहुत ज़्यादा बात होती है कि how sustainable is the program or how we can make it sustainable in simpler words. So we are already mandated by the Prime Minister of Pakistan, Miami Sharif Sir, and we are presenting him next month a formal proposal and summary to how to make it more contributory in for the affordable segments. So we are coming up with a multi-pronged approach just for the consumption of this worthy group, that we are suggesting as the low-hanging fruits some co-payments from the affordable segments, and in the medium to longer term we are coming up with the medium and upper class some contribution mechanism where medium can give a moderate contribution and higher segments can give a more significant contribution, and the below poverty segment will remain under subsidized by the government of Pakistan. So we are covering through co-payments, sustainability. We are covering up with the contribution plan coming up, and we are going to start the next fiscal year, inshallah. And third one is we are just working on managing this double dipping issues or duplication of the coverages as well. Because today there are multiple pools, as Dr. Razia highlighted very wisely. There's so many things are going on parallel in silos. So all these now pools are very small when compared with the Sehat Sahulat program. The Sehat Sahulat program is, mashallah, 70-80% of the total pools or other pools. But these duplications need to be sorted out. And we are now introducing and sending a summary to the Prime Minister. Even for the civil servants and the public servants, we are just integrating them with the Sehat Sahulat card with the top-up option with their own benefit entitlements. Similarly, with other autonomous institutions, social security institutions, we are discussing and how to gradually and slowly we should unify the coverage and make one pool or integrated pool, I must say, for the economies of scale and for the wider coverage. Maybe the baki pools, they can support more on the primary healthcare side, and we should keep focusing on the secondary care and tertiary care side. But there should be some integrated approach which should be used for the benefit of the people. As we see region, United Arab Emirates, around now they started around 17 years ago, universal health insurance in UAE, and then followed by the Saudi Arab back in 2008 onward. So they come up with a slightly different model. For example, UAE come up with a sponsor-based or employer-based model. So they said whoever the employer, the public sector or the private sector, they are responsible for their coverage. They authorize the insurance companies, and this expat population or the public sector employees are covered by the government of United Arab Emirates. Saudi Arab adopted a similar model, but in that case, now the employer was shouldering the financial responsibilities for their employees, and government is providing them a top-up coverage or a coverage as a last resort. For example, in UAE, just for the sake of simplicity, that the government has issued a subsidized plan for the laborers or the low blue-collar population, and they showed, like State Life Insurance Corporation of Pakistan, they have a public sector insurance corporation demand that whenever the claims losses will go on the certain threshold, the government will. This is how more and more players at individual level or organizational level to contribute to make the healthcare and especially the universal healthcare programs more sustainable in the longer way. Same thing we have suggested to the Prime Minister of Pakistan or the federal government political leadership. Now, after the rolling out of the universal healthcare, I just be very brief in the last few sentences, close my remarks. That we're focusing on long cost for the program, how we can make a strategic purchasing so we can reduce the cost of inputs for the treatment, and quality monitoring. Now we have signed an MOUs with the healthcare commissions, so they can play their role, and we are conducting clinical audits as well, just to ensure whatever the treatment kind our patients are receiving, it should be reasonably meaningful and worthy value for money, what we are spending for them. And last but not the least is that it's not only expanded the service delivery database with inclusion of more and more private sector facilities in the remote areas where previously they were not available. But with a unified database is very helpful for the overall public health sector and overall government policymakers for the healthcare sector. This was a general brief. I'll be open for any further questions. Thank you, Dr. Razia.
Thank you very much, Arshad Saab. Very encouraging and very hopeful and very positive points you have mentioned about our future of health in Pakistan. So that's very good and very encouraging. And as you have mentioned about the quality of care. So what innovation we are, because I have gone through the reports which are just perceived quality of care. But what is the actual quality of care? Is there any assessment on that? And the second is for example, the utilization rate in Punjab or in ICT is still low. So how they can be improved? And I would like your comment on quality in detail, or if you may like to, please. Thank you.
Dr. Razia, I have heard your half due to some, I think, internet quality. But what I understood, let me answer for that. One is the quality part, as you said, okay, how we are ensuring the quality. We have recently introduced the treatment protocols with about a few faculties like cardiology and some other areas, orthopedics and some other areas. And gradually we are introducing these treatment protocols to ensure a standardized quality treatment for all our patients. But we are getting at multiple level patient feedback as well. Instead, in addition of the routine monitoring activities we are taking place through third party NADRA, we are getting patient feedback from every discharged patient just to ensure what kind of service perception he has or she has and how they wanna give us a feedback. But now we are coming in a broader way, that we are hiring and including firms which will be comprised of very professional clinicians of different facilities. They will be giving a third-party clinical audits periodical for every year on almost every facility, just to ensure that it's not only the treatment our people are receiving, but it should have a minimal benchmarks which should be achieved by all the healthcare facilities. We have, during last 1.5 years, de-panelized 53 facilities only due to multiple complaints, especially with the clinical issues, with the monetary issues, or with the attitude issues, all three. We cannot tolerate. And now the other facilities are understanding it very much, that by not treating properly a health card patient can cost them like anything, because they are going to lose a big customer. It's not a one individual customer like Dr. Razia or Muhammad Arshad or anybody else. So now they are more careful. But I think, having said that, there are much more need to be done in collaboration with the healthcare commissions, who are primarily responsible by their legal mandate to ensure an external quality view for all the treatments provided by the government or the private schemes. So we are trying to work hand in hand with those institutions. If there's any second question or second part of your question, if I missed, you may repeat so I can answer, please.
Okay, thank you, Arshad Saab. I think well answered. My query was well answered. And now there is, with the informal discussions with colleagues or with patients, I could grasp some things which I would like to share with you, or would like to ask you to pay attention on that. Like, for example, many of the gynecologists have said that previously the patient, with the start of the universal health insurance, with the previous for example, they who were affording patients, and they were giving the fee for the service. But now they are under the health insurance program, and they are topping up with the hospitals. And many of the hospitals are converted to the social health insurance programs, hospitals. Like, for example, they are giving the patients care, but they are the patients top up according to their requirement. Is there anything like that in your notice, or something like how can we, like for example, I made the example of the Taiwan for overutilization as well as for the frauds and all these things. Do you think that there is something like that at the moment?
जिसमें रज़िया honestly गुजारिश ये है कि we are having a very strict eye on such instances, but we do receive such grievances from different quarters, and we do call explanations, and where issues are serious nature, we give them either warning or de-impanel them. Because now, since it's universal health insurance, many people think they can get benefit of the basic coverage with the health card through general ward service, and they can make an arrangement with the hospital with some little pay to get a private ward, for example. But we discourage this thing at this point of moment, because we don't want to involve the cash element in this cashless treatment arrangement, because it can open a new door. In future, we will be introducing an official top-up coverage facility where Dr. Razia or Muhammad Arshad or Dr. Alia or Dr. Shehzad can top up for their facilities. So they can pay through the official, they will get another health card, top-up card, and you can submit both the cards, your Shanakhti card, CNIC, along with your top-up card, and you can get a health card from the healthcare services, and you can top up as per your requirement. So we do are catching such incidents where these informal things are taking place, and now these things are reasonably under control. We got few instances, especially in the South, Punjab, and few Lahore areas as well, and in Peshawar city. But now situations are much better, but we are considering very seriously to introduce official top-up coverage later in this part of this year. Thank you.
Thank you, Ashish. Now we have Dr. Alia with us, who is very renowned economist in Islamabad, and we are very thankful for her to joining us for joining us. And she has some insights. She was the head of department at Qaid-e-Azam University, and currently she is on the board of the Khyber Bank. And she is I think only labor economist in Islamabad and in Pakistan, and she has many caps which she wore and she is wearing. And over to you, Dr. Alia, for your comment, please.
Thank you, Dr. Razia, for such a gracious introduction. And I'm just going to be very simple, because I think even if the parliamentarians have not joined up till now, I would like to speak of universal health coverage and social health protection, social health insurance in a manner which I think should be communicable to the political leadership, because up till now I have not seen a very strong political commitment regarding the sustainability of this scheme, and maybe because of the way the political situation has been evolving, there hasn't really been time to devote much attention to it. But anyway, so I would like to focus on issues of coverage, because I was reading up on the coverage issues of social health protection and social health insurance schemes. And Dr. Shehzad did point out that for countries, even, which we consider as high income countries, it has taken decades to achieve universal health coverage through the expanding the coverage of social health protection. And in those countries, the divide between the formal and the informal sectors was not that acute. The majority of the population was documented and, under the umbrella of what we call formal sector. However, we do have a huge informal sector, and therefore it remains a challenge as to how a universal health coverage through social health protection is going to reach the vast majority of the population, for whom out-of-pocket expenditures, not only on secondary and tertiary healthcare, but primary healthcare are also a big issue. So the major, I think, this issue to be discussed is how do we mobilize adequate resources to increase and ensure coverage of the health needs of the majority of the population in an incremental manner. Of course, no country has been able to achieve universal health coverage overnight or through revolutionary mechanisms. And there is also, the literature also suggests that there is no unique model of health financing. And listening to my two respected colleagues, Dr. Arshad and Dr. Shehzad, I do realize that the Sehat Sahulat program model in Pakistan is at quite an advanced stage. But again, I would like them to ponder on whether the way it is being financed, that is exclusively through budgetary financing, and we know that it is not tax financing entirely, because the tax mobilization in tax revenue mobilization in Pakistan is not very robust and satisfactory. In fact, it is one of the major reasons why Pakistan is undergoing very repeated IMF programs, is because we cannot finance our fiscal expenditures through domestic resources, and we need to borrow from foreign sources. So in this kind of scenario, how do they foresee going forward that the financing requirements for social health insurance would be sustained? And I would just point to the the kind of mixed approach that you also pointed out, and that is being followed by many African countries as well, which has led them to increase the net of coverage by combining different approaches. So, how long can Pakistan just rely on government financing to sustain its social health insurance? So that is one question. And secondly, I would like to raise this question of, having these two parallel systems. One that is through the social security schemes of the provincial and the federal government for the formal sector workers, and the other one which is the Sehat Sahulat scheme. Has there been any exercise of or brainstorming about a merger of these two schemes? Because having two different schemes also means that there are a lot of inbuilt efficiencies being associated with the Labor Ministry and the provincial labor departments, and Dr. Razia, you with your wealth of experience of working in the social security system at the provincial level and even at the federal level, you understand that there are many institutional costs of having that system, which can be cut down if the schemes were merged. So, I mean, I'd just like to raise these issues. And also, I think there should be a lot of more political awareness on health financing policy. I mean, when we talk of a health policy at the national or at the provincial level, sometimes the issue of health financing does not figure as clearly or as importantly as it needs to figure. So I think we need to lobby with the parliamentarians on this issue of health financing also. So this is all for the moment from my side. And yes, I would also like to add that I read that Mexico has used value-added tax on sugary drinks to cross-subsidize social health insurance. So we can also think of innovative solutions to raise revenues and cross-subsidize the social health insurance financing needs. Thank you.
Thank you very much, Dr. Alia, for such a wonderful overview, and as well as the suggestions which are practical, and I think which can, in the long way, we can think parliamentarians or the policy makers can think about that, and they should include these, for example, the utilization of the social security system already existing. And with my experience, they have the state-of-the-art hospitals, they have the human resource, they have so many positive or so many already established systems which can be utilized. And the social health insurance has the very strong health information system, which can combine together, and they can bring out all the disadvantages of the one system, and can bring out the advantages to the other system. So that is great. And I think Taiwan, they put all these systems under one roof. That can also under one umbrella. That can also work. And on this, I would like to ask Dr. Shehzad Ali Khan for what about the pooling of or combining all the systems together to reduce the cost, as well as to co-financing, or we can deal with the better with the larger perspective. And the other question to you is Shehzad has lost the connection. So these are, I think, Dr. Shehzad, you can ask him to join again. We can ask Mr. Arshad this question,
Sure.
How about to utilize all these things? And I welcome Dr. Shazia Sobia, our parliamentary secretary, and thank you very much, Dr. Shazia, for joining us. With your tight schedule, I understand that you were in the assembly and you have joined. Thank you. And over to you, Mr. Arshad Saab.
Thank you, Dr. Razia. I will respond very briefly. A couple of points raised by my respectable colleague, Dr. Alia, and a couple of colleagues online received from Dr. Minhaj and Mr. Wahid Miraj also. Almost same issues, same topics, so I will try to answer in one go. The key issues mentioned by all of the colleagues is, again, which I mentioned in my talk as well, is duplications. As I said, दुनिया में जहां भी कोई एक निजाम जब दूसरे निजाम के साथ ट्रांजिट करता है, there is an interim period where these duplications happens, and gradually these programs, the mainstream program like Sehat Sahulat program, which is covering now 80% of the population of Pakistan, both in terms of the resources and coverage, तो वो naturally overlap करेगा बाकी चीजों को. और अभी we are recently sending a civil servant summary and we are discussing with the ESSIs, हमारे social security के जो इदारे हैं. We are also discussing with the armed forces as well to bring in all this CMH hospitals on our panel and to provide some top-up coverage by the armed forces. So हम कोशिश ये कर रहे हैं with the autonomous organization, even with the private sector. People are contacting us. Okay, the Sehat card should be the basic coverage and we can get from the private insurance company top-up coverage. And we are open for that. We are saying them that gradually we need to remove all these duplications, as wisely said by Dr. Alia, not only to ensure the efficiency and better use of the resources, but to make it more effective as well, because in the duplications, many kind of inefficiency happens. Second thing is the good news for Dr. Alia and the rest of the group is that Ministry of National Health is already working on the health financing strategy framework. Just to ensure first time in our 75 years, we already had 4 sessions of the working group and with the World Bank, with the WHO, with the all provinces and all the stakeholders. And hopefully down the road, next 6 months, we are coming up with a very comprehensive and very at par with the international standards, a first of its kind national health financing strategy. We are working very closely with all the stakeholders. And one question asked by Wahid Miraj, everybody calls this again with sustainability issue. Just is the main issue is with this resource channelization, I must say. Currently, Pakistan government, with all its 4 provinces and 2 regions, is spending over 1,000 billion rupees in the current fiscal year on the public health budget. I'm excluding the army budget and the civil servant budget and the corporation budgets. Mainstream public health budget is count 1,000 billion rupees in the current 23-24. While if I covered include even the Sindh population as well in the program to make it 100% coverage for every Pakistani, my ticket size with the health card annual cost will be only 225 billion, which is means 22.5% of the existing healthcare cost. We can provide this catastrophic healthcare coverage under the UHI. So it's all about channelization of the resources, but still not depending on public health budget. We are coming up to make sure a mere contribution mechanism where this program can be self-sustained, and also we can remove the duplications which can add further value. And last but not the least, as mentioned by Dr. Razia, that we can be a little bit more creative. Yes, we already experimented this creativity back in 2019-20. We imposed a health tax or health levy on the fizzy drinks and on the cigarettes, and for the Sehat Sahulat program, and we collected over 40 billion rupees 4 years ago. But unfortunately, due to some bureaucratic red tapes or some other issues, those stuff were not received by the program directly, but it went to the government treasury for the sure. And we can take some more steps in their direction or any other right kind of mix we can develop with the co-payments, with the contributions, and with some value-added tax to ensure to provide the universal health coverage to all the people of Pakistan. And one small comment with regard to Dr. Manhaj query. Yes, we are not paying the hospitals, 1,082 hospitals across Pakistan, on fee-for-service based. We have already developed DRGs based healthcare packages for all 1,500 plus kind of disease or procedures. So we do have a control, and we are working on the clinical audits just to ensure the quality as well. Accreditation body is already available, which is healthcare commissions, but maybe in future we can develop one more if needed. Thank you.
Thank you, Ashitab. Very important information you have given us, and I think we are going towards towards the positive side, and inshallah, with the time, I think this will be the best system. But what about the our parallel health system, public health system? So are we utilizing it? Like, for example, one of from the KPK, it was transpired that the 70% of the beds in the public sector are empty. They are not being utilized by the social health insurance. But the private hospitals, like the private beds, are utilized more. Are we going to do something about that or something? But because you mentioned about that you are increasing the spread of this, empaneling the hospitals, like army and other organization hospitals are being empaneled. So what about that? How can we take care of? I understand that quality of care is the issue, where the perceived quality is the most is thought most important, because the patient has to wait and in the public sector hospitals, otherwise the other quality. So what are your plans for that?
Thank you, Dr. Razia. Very, very valid question, I must say, at this point of time. Based on my 30 years plus health insurance experience across the world, what I strongly believe is public sector health sector is always more strong in terms of good service delivery, because they have a better infrastructure, best faculty available, and most of the time best treatment equipment as well. But the only issue is maintenance or customer-centric customer servicing. That is the key challenges. So we are working very closely with public health facilities just to include them more and more, just to utilize their beds more and more. But the basic principle of this program is merit-based healthcare service. We never force our beneficiary, and we give them full liberty to make a choice wherever they want to go based on their quality perception, based on their last quality experience for the service delivery. But now gradually in KP, initially it was 15%, now 25%. All the hospital claims are coming from the public sector, which is again going back to the government treasury. Same in the Punjab, now it's 32%. Claims are coming from the public sector facilities. In federal areas, it is 48% claims are coming from the public health facilities. We are working closely with the PIMS, with the polyclinic, with the GB DHQs, with the AJK DHQs. The only challenge is of two kinds. One is their 75 years old paradigm, where they don't focus the patient as their business. And second thing is, they don't have infrastructure to provide a cashless service. Our program module is patients should not touch the cash. Everything should be provided by the hospitals. As you know, by your own experience and your own research and project, Dr. Razia, in the government sector, the things working in silos, where pharmacy is working in one direction, diagnostics are working in the other directions, doctors are working in the third direction, and paramedics are in the fourth direction. So it's a big war, big struggle, big strife, but we are preaching, we are incentivizing, we are motivating our public sector hospital colleagues, and more and more hospitals are performing well. I will close my remarks with one last example. I went 2 months ago in Muzaffarabad just to visit this Muzaffarabad CMH and DHQ hospital. All of you must be knowing there is a joint hospital, DHQ and CMH, Muzaffarabad, the best hospital. So the commandant of the hospital, the brigadier, he was escorting me for the hospital visit. And he said, Arshad Saab, just because of this Sehat card facility and additional revenues, we were able to maintain the hygiene and cleanliness in this hospital. We hired a 50 persons army for only cleaning and making the hygienes. We built up with the additional revenue another 50-bed female emergency ward for only females, because it's the biggest hospital for the AJK, and another 15 beds CCU, which was otherwise not possible due to fiscal constraints from the both Khaki side and civil side budget constraints. But this additional revenues, now these additional revenues are making public sector hospital more a corporate company, where ownership will remain with the government, where the cash flow from the government will be reduced gradually, and more people not more and more, almost all the people will be coming with the health card. So nobody will be the free customer. But when there's a free, not free customer, they have their own expectation of the services. But those where the leadership is good in public facilities, they are transforming fast. And where there's an issue of the leadership, this is taking at a lower or slower level. But I'm very hopeful, and we are working very closely just to make use of 100% of our public sector health facilities with a better customer servicing. Thank you.
Thank you very much, Arshad Sahab. I think this is a good news that we are working on financial health policy, financing of health policy and financing policy for health. So that will be great. And I think my strong request will be to include the maintenance of the hospitals, public sector hospitals, in this policy, so that the funds are adequate to maintain these hospitals, because they have very good quality of the machines, and the human resource is very good quality. But because of these, you mentioned about for example, the lab and pharmacy, they are working inside separately. So that will be great if we that maintenance they were fixed in, I think, 20 years ago, but still they are the same. So that will be great if we can include that that one in that. Thank you very much. And now we have our esteemed and very Parliamentary Secretary Health, Dr. Shazia Sobia Suno, who is always kind to us for joining us, and she herself is a doctor, and she has she belongs to a party which is always pro-people party, and and they have done many interventions which are taking care of the poor people, and one of them was the BISP initiative, and which and the Wasila Sehat was part of that BISP, which which were converted to the Sehat Sahulat program, or the Prime Minister National Health Program. So over to you, Dr. Shazia Sobia, and she is. Thank you very much for joining, and over to you for the many questions are coming up from the audience also for the synth, and also what is your for the next election, what will be your party's standing on this social health insurance? Thank you very much. Over to you. Thank you.
Thank you. Bismillahirrahmanirrahim. Can you hear me?
Yes, we can hear you.
Okay. Thank you, Dr. Saab, and thank you for inviting me. As you mentioned that this is a program like Wasila Sehat program on the platform of Benazir Income Support Program. That is the first initiative of the Pakistan People's Party for the people of Pakistan. I think there is no compromise on the health of anyone. And that is mentioned in the SDGs, that no one left behind. That I think our manifesto mentioned that Pakistan has made several commitments internationally and to its people for the provision of healthcare, particularly to the most vulnerable. And I think the main thing is for the health of the people, we are contributing on the, first of all, sustainable development goals, and the other thing is family planning. The one reducing maternal mortality rate by 2030 to 70% per 100,000 live births. The infant mortality rate to the 12 or less per 1,000 live birth, and the under 5 mortality to 25 or less per 1,000 live births. These are our party's manifesto part, and in other words, we are working on ensuring the universal access to sexual and reproductive health is a part of national strategies and the programs, ensuring sustainable increase in the health financing in the order to support health services and the training and the retention of the health workers, and the monitoring and evaluation of all health personnel throughout the e-monitoring system. Dr. Zia, as you mentioned before, that we are working on so many, sorry, my throat is not allow me to talk so much, but I can try to contribute my program or my contribution working as a parliamentary secretary or being a representative of Pakistan People's Party. Sorry. And we are also, the example is in the Sindh, we are working on health services like NICVD is the best and a big example in the world. And other is SIUT, is a public sector hospital. And Gambart Institute of Medical Sciences is a public and private sector partnership, public and private partnership hospital. And JPMC, NICH, and Benazir Trauma Center. These are the best example of the improvement of health services in the Sindh. And the other thing is social security benefits for the people. In the sickness, there is 75% of wages in after last drawn, and employment injury 100% wages, death grant 30 days of the sickness benefit subject minimum 1500, and maternity 100% of wages last drawn, and disablement, that is if the degree of disablement ranges between 1 to 20%, and the survivor pension 75% of wages last drawn. डॉक्टर जी, ये सारी चीजें वो हैं जो हम अपने मैनिफेस्टो से या हमने जो काम किया है थ्रू लेजिस्लेशन और थ्रू एज अ मेंबर ऑफ पार्लियामेंट, but we are working on the coordination between all provinces and all district level health services. सबसे बड़ा जो हमारा contribution है, मैं समझती हूँ MCH में, मदर चाइल्ड हेल्थ में, that is PPHI, जो हमारी BHUs और RHCs थे, उनको हमने PPHI के इनिशिएटिव के अंडर उनको हमने हैंड ओवर किया है, और दे आर वर्किंग बेस्ट. एंड सॉरी, मैं इतना ही कंट्रीब्यूट कर सकती हूँ, माय थ्रोट इज नॉट अलाउ मी टू स्पीक मोर. थैंक यू सो मच. अगर कोई क्वेश्चन है तो आई कैन आंसर. थैंक यू सो मच.
Thank you very much, Dr. Shazia. I think you had sore throat, but thank you very much for contributing this much. I think I was as I mentioned earlier, that the Sindh has good indicators, and the PPHI is the flagship program there, and the Gambart Institute you have mentioned about it's doing the wonders in the when I visited the Gambart at that time, it was it seems that it's nowhere in the land of nowhere, but I think it has picked up, and what a big service they are doing it. And
I can tell you the cochlear implant at Gambart Institute is free of cost. The liver transplant, kidney transplant, and the bypass surgeries are free of cost at Gambart Institute of Medical Sciences, and also oncology unit is there, and that is also free of cost. These are initiated by public-private partnership by Sindh government, and I hope, and these initiatives are also in the SIUT. The oncology unit is free of cost. The liver transplant is free of cost. The kidney transplant is free of cost. There is so many surgeries are done in the SIUT without any cost. These are the, I think, flagship or big examples for the all over the country or all over the world from the government of Sindh.
Thank you very much, Dr. Shozia. But can you please give us 2 lines on the adoption of this federal health, social health insurance program in Sindh, or so that it is really like covering the Sindh also? Many initiatives already working in Sindh, but if for the equity or equality, if we can think about that, what is your plan the next in your after the next elections, or in the for the recent government of Sindh, or and any plans for that? Or as Mr. Arshad has mentioned about including the 5 districts already, but any other plan for universally covering the population in Sindh?
As Dr. Arshad mentioned that inshallah, these are in the pipeline plannings, and I think Tharparkar is completely covered, 100% covered by Sehat Sahulat program, and we are working on the other districts of the Sindh and the Balochistan to cover the under the Sehat Sahulat program, and also Chairman Bilawal Bhutto Zardari Saab mentioned that we are working on same initiatives we are taking in the Sindh, and now we can take these initiatives to the federal government and improve the health facilities in federal government hospitals like PIMS, FGH, Polyclinic, and other hospitals. We are working on that, and these are pipeline programs. Inshallah, we'll working on that, and result will be in front of you soon.
Okay, thank you, Dr. Shazia. Dr. Shazia, another question is about the quality of care at these hospitals. As I mentioned earlier, that most of the surveys which are done by the by the hospital administration or by the third party, they are the perceived quality of care, which is perceived by the patients, which is usually the feedback surveys. But the quality is the technical quality of the services, which is like as earlier is being mentioned, but they, because of the resources and because of the maintenance and all these things, we're lagging behind in that. So is there any plan of with the ministries to get the assessment of these hospitals? Because I think this is the right time to do the assessment of the technical quality of these hospitals, because they have the huge budgets. And but the patients, they are always with the slips going out for the labs and for the blood banks and all this. So any plans in your at ministry or at your knowledge that we can do the technical quality assessment of these hospitals?
These are also pipeline programs, and we are, yes, you are right. There are so many lacking, there are so many negligency in technical support, and we are working on that. And we are starting so many skill development programs regarding nursing care and other technical partners. And some of the programs are, I think these are on working with some international partners and some with the local NGOs. We are working on it, and inshallah we will take over all the negligencies, and our technical issues will cover soon. And also you can see these problems. When I was president of Pakistan Nursing Council, I faced these issues many times. Technical issues, nursing training, these are major issues of the Pakistan. We have focused on these issues, and inshallah you will see the result of these technical issues.
Okay, thank you, Dr. Dr. Alia, a small question for you, so that Mr. Arshad has mentioned about the financial policy. May I ask you a small question? What is the key to make a successful financial policy for health? If we want to cover all the people and toward moving towards the universal, obviously it will not be one-day program, but it can take decades. But what can be the key issue? Like, for example, if I think about that, I think the revenues should be generated. Like, for example, it was mentioned about the syntax or the health on the tobacco or the sugary drink beverages. You mentioned about that, and that was in the plan, and the 40 billion rupees were collected, as Mr. Arshad has mentioned, but they are not still redirected towards the health. So what is your comment on that? Thank you.
Yes, thank you, Dr. Razia, and thank you, Arshad Saab, for informing us and the audience that the health financing strategy is in the works. That is very heartening, because I think unless we combine the health financing issue with the health needs, we cannot achieve sustainability or ensure or even project sustainability of a health insurance program. So I would just say that on the basis of the research that has been conducted, and it is an evolving area of research, and especially after the COVID pandemic, this research has intensified, that countries now really need to focus on the health financing issues of country. And I think what I can say is that a mix of both government financing, which is basically mobilization of tax revenues through cross subsidization, because I would not say that, you know, all indirect taxes are progressive. I mean, some are very regressive, and the burden of the indirect tax or the value added tax should not fall on the segment which is supposed to benefit from health insurance. So very carefully worked out cross subsidization of tax revenues, and of course directed towards health financing. What Dr. Arshad Saab mentioned about you know, collecting VAT from sugary drinks and that not being directed towards health financing is you know, a telling statistic in itself, that you know, we need a political commitment that the VAT that is being collected for financing of health needs should go towards that goal. And also, I would say that the government alone cannot finance the needs of the entire population. So we need to shift from you know, having the burden of the universal health insurance scheme entirely being on the government to a partnership system. And I do see the elements of that in what Arshad Saab and Dr. Shehzad mentioned. So I think we just need more communication with the relevant stakeholders on this health financing strategy. And I'm so glad that Dr. Razia, under your leadership, STPI decided to
Dr. Alia,
hold this
आपकी आवाज नहीं आ
seminar.
रही.
जी, अब आ रही है? हेलो? जी.
जी हमें तो बहुत अच्छे से आ रही है डॉक्टर आलिया.
जी जी.
डॉक्टर रजिया से
सॉरी,
पूछें.
डॉक्टर रजिया को कोई मेरे ख्याल से इनका वो STPI के एंड पे कोई इशू है. सो आई जस्ट स्टॉप हियर. अब आ रही है डॉक्टर रजिया?
जी जी, अब आ रही है, अब आ रही है.
अच्छा नहीं, बस मैं आई वाज थैंकिंग STPI for convening this very important webinar, because I think now after COVID especially, there is a strong felt need for enhancing the net of social health protection through social health insurance. And I would say that the academia also needs to focus more on conducting research and helping the government as well as the private sector in identifying the tools for social health financing, policy. So I'll stop there. Thank you.
Very much, Dr. Alia, and Mr. Arshad is with us. And Mr. Arshad, we have a few questions from the audience, if you may like to reply. That do we plan to include Afghan refugees in this program in future as a step towards universal and leaving no one behind? And the second is like this is from my side, that the recent floods has shown us that the social health insurance, like obviously we did the emergency programs or emergency interventions, but is there any plan for the social health insurance to keep some funds or to facilitate these emergencies? Thank you.
Thank you very much, Dr. Razia, very wisely asked. जब 2021 के आखिर में हम ये यूनिवर्सल हेल्थ इंश्योरेंस करने जा रहे थे, तो एट दैट पॉइंट ऑफ टाइम आई प्रपोज्ड कि ये नहीं हो सकता कि सेहतमंद पाकिस्तान के अंदर अफगान रिफ्यूजीज का एक बीमार जजीरा हो. So we should include these, but at that point of time, my colleague, Mr. Dr. Faisal Sultan, and Prime Minister then, they advised that we are already doing a big project, so first roll it down for the national level, and then we can consider for the other community segments as well. So I am grateful to the current government and Honorable Prime Minister Sahab and Health Minister Mr. Patel Sahab, that now very soon we are including our Afghan refugees also. I have talked to the United Nations, and UNHCR expressed their willingness for the funding of the project. We are conducting very soon a pilot project with the UNHCR for Afghan refugees inclusion in the program. And after the successful of pilot, we will be covering all the 1.6 million NADRA registered Afghan refugees, inshallah, in the program with the help of the UNHCR. And there was a second question raised by you also, which was regarding what?
Floods.
Emergency
yeah,
exactly. We are lucky enough. Let me share a good news for all our colleagues in the group, that previously when we hit in all surprise by this pandemic, COVID, we were forced to establish new hospitals, especially in the areas where not available, allocate the beds and so many things. But luckily now we have a vehicle available, which is this universal health insurance program. Now tomorrow, any catastrophe happens, whether it's a flood, whether it's an earthquake, God forbid, whether it's another pandemic like COVID, all the federal government and provincial government has to decide on the top. We have a reserve fund facility within our benefit package. We can pool the money in that package, and with the one email to the insurance company, we can communicate all 1,082 plus public and private sector hospital to provide this extra cover or special coverage to all our 190 million plus Pakistanis, or even more. For that purpose, we include the Sindh and Balochistan, everybody, for these facilities without making any panic. That's the good news. In the whole South Punjab, whole of the KP, recently benefited with the social health insurance program during these flood areas. And very soon, as mentioned by my colleague and my senior, Dr. Shadia Sumro, that we are discussing with the provincial government as well, how we can develop the synergy, as is the discussion of the provincial government. And we are learning with the good facilities created by the Sindh government, like NICVD, and very viable network of the cardiac facilities across Sindh, then SIUT and then NICH and the Gambit Institute. And we have requested Chief Minister Murad Ali Shah Saab to include these facilities, public facilities, in the Sehat Sahulat program to get benefit for the Sehat card patients, because I don't want to channel the money, the Sehat card holders residing in the Sindh province, to the private sector facilities only, because when we have a state-of-the-art Sindh government built facilities, we should get the services of these hospitals, and the funds which are being otherwise channelized to the private sector, they should go in the Sindh government's kitty for further strengthening these wonderful and great facilities across Sindh. Thank you.
Thank you very much, Dr. Shazia, Sobia, Dr. Alia, and Arshad Saab, for your very important contributions and giving us the light at the end, and especially Mr. Arshad and Dr. Shazia. So we are hopeful that we all will be seeing this program growing with the exemplary speed, as in the I mentioned previously that it takes decades to, but we are still, it's not a decade, and we are already progressing towards the universal health insurance. Thank you very much, all the participants, for putting up good questions, and thank you very much all. And these are all your points will be included in this our write-up. And thank you very much. Always, you are always kind. Thank you.